Hello to everyone. And it was really great to hear some thought-provoking conversations in the first few talks. So I'm Dr. Saqib Latif. I'm a clinician, consultant child adolescent psychiatrist. I've been here in the UAE for the last about 2.5 years. Before I was in UK, South London and Kent area, primarily working with children and young adults. So the main reason, well, I went into my profession as a child psychiatrist was around really why I'm presenting this topic today. So I'm going to briefly mention that, which is to really get to the root cause of why is it all there. So root cause of mental health problems, really. So today what I'm going to talk about is quite close to my heart, and it actually relates nicely to the previous talk, because there is, of course, the mention of trauma, and we are going through a very difficult time phase, the COVID-19 pandemic, and we have talked about the impact on the neurological structures. So I'm also going to highlight a different angle, not only of this trauma, but generally the importance of psychological trauma on the mental health of not only children, but throughout the lifespan. Because I think that's really the main reason, and that's really one of the main factors in the etiology of a lot of mental health problems. So just to begin with, I don't have any financial disclosures or conflict of interests with any presented material in this slide. So what are we going to talk about in the next half an hour? Of course, I'm going to talk about what trauma is, a little bit about definition, the impact, how, and then we'll talk about why really it's important. I am going to be referring to the ACE study, Adverse Childhood Experience study done by the Center for Disease Control and Prevention, US, at the Kaiser Center, the famous Felicity study. So a lot of data will be coming from that. We'll talk about the epidemiology and then the impact of trauma. We'll talk about some etiological factors, and then we'll talk about PTSD as a clinical construct, the clinical presentations, and then finally, we'll talk about the concepts of resilience and trauma-informed care in the management. So, what are we talking about? If you can all see, this is from the Felicity study, the trauma, we are talking about psychological injury. What is trauma? We use it as psychotherapists or psychiatrists or clinicians. We often use this term quite commonly. But for any other colleagues, we are referring to any event that is threatening or perceived as threatening for the individual. So you can relate to to the normal physical injury. And after any physical injury that you get on the body, there is a process of healing. Similarly, after the psychological injury, there is always, or there should be, a process of healing. And we'll talk about sometimes when it does not happen, then that can lead to a lot of mental health problems. So trauma is a psychological injury that damages or harms the individual, though the severity, longevity, and permanency of that harm may vary. So same event that may be extremely traumatic for one individual may not be traumatic for another individual. So the perception of the trauma is more important than the facts of the trauma itself. That's an important bit. We are talking about abuse, neglect, and household dysfunctions. There are lots of different types of trauma. Conventionally, we talk about the physical, emotional, and sexual abuse, and neglect in the form of physical and emotional neglect. These 5 types of psychological injuries are quite common, and we talk about them a lot of times, but they are not the only ones. Those of us who have been working with children or adults in our lifetime, we know that there are lots of other different types of traumas, including history of mental health problems in the family, domestic violence, parental divorce, and a relative being in the prison, history of substance abuse in the family. These are few other very common traumatic incidents that have been found in that survey. But that list is not complete. There are lots of other different types of events that can act as traumatic for particular individuals. So what we need to really talk about is potentially traumatic event rather than the trauma itself. Because as I said, that one event may be very damaging for one individual, but may not be for the other. It's about how that person is perceiving. And that's what I always tell the families that I see, that children perceive things differently. We cannot understand how that child was feeling at that particular time because we think from our adult brain. So the potentially traumatic event is an important concept. Of course, there are different types of degree. A minor trauma could be a teasing at home. Usually you don't need much time to overcome that. A moderate degree of trauma could be bullying in the school, for which you need a longer period of time and support to overcome. And severe psychological trauma in the form of sexual abuse, familial sexual abuse. These types of trauma, if they are chronic, they can have a severe, long-lasting impact on the developing brains especially. Of course, the duration can be acute. We can have the symptoms soon after the event, or the chronic trauma can have long-lasting, lifelong impact. And there is also the concept of delayed discovery. When after the trauma, there were almost no symptoms, but it can come after many months or even years. And that happens very often with the victims of abuse. We've talked about child maltreatment. That's generally considered to be quite common, one of the commonest ones, in the form of abuse and neglect. But as I said, that it can be a form of domestic violence, financial problems at home. But it can also be in the form of community violence, being a victim, or just witnessing a fight, some sort of a trauma at school can itself be traumatic. If you're going through a natural pandemic, different types of disasters like hurricanes and fires can be different forms of trauma. Road traffic accidents can be there. Of course, wars and terrorism, which are quite rampant around the world currently, they can act as trauma, and we need to know the impact of those events on the growing minds because the children are present everywhere. But again, there can be rather those subtle types of trauma which are happening right now in the comforts of our own homes. Maybe our children in their bedrooms are suffering from some trauma when we think that they are actually quite safe. And I'm referring to cyberbullying. So bullying at school or cyberbullying through the use of social media is a very significant type of psychological trauma that are impacting on the minds of children. But as I said, there can be many other different types of trauma. Let's talk about how common it is. It's definitely more common than we think. A lot of statistics are coming from the Western part of the world. So I'm going to present just some statistics from the CDC reports. That 1 in 5 children sexually molested, 1 in 4 beaten by the parent to leave a mark on their body, and 1 in 8 has witnessed domestic violence. Now, these are significantly more than what we would like to assume, that we are living in a nice, safe world, but actually there are a lot of trauma going on right now around us. And in the study by Copeland and Finkelhor, more than 60% of youth in US would experience a traumatic event before adulthood. It's not easy to do the epidemiology for these types of studies because, you know, the taboo, there is a big barrier about in different cultures that we mustn't talk about them. And that's why we are talking about these statistics coming from a particular part of the world. It is possible in different cultures or different parts of the world, the numbers are not that same, but the experience and limited number of studies that have been done actually show that the rates are not much different. The abuse is definitely more common than we think. So in talking about how common the ACEs are, the adverse childhood experiences from the Fidelity studies, yes, it is talking about 60% of the young people experiencing 1 or more of the adverse childhood experiences, those out of 10 that we talked about, the abuse, neglect, and household dysfunction. About 25%, a quarter of the young people would have at least 1, 13% 2, 8% 3, and about 14% would have 4 or more. Why is that significant? We will see in a minute. Because if you have 4 or more adverse childhood experiences, that really raises your risk for developing further mental health and physical health problems throughout the lifespan. Let's talk briefly about the impact of trauma. It's not only about the acute stress disorder and PTSD, which are the trauma-related disorders according to the DSM, and we see and we think about, but actually the impact is on a number of other mental health problems, including the emotional disorders, anxiety and depression, but also lots of other risk-taking behaviors, behavioral problems like conduct disorders, antisocial personalities, but the risk-taking behaviors are very common that we see, like substance use disorders. But there are so many other symptoms which don't really fit in any ICD or DSM criteria, but we see on a regular basis in our clinics, like self-harm, suicidality, lots of internalizing or externalizing behavioral problems. And then, as I mentioned about the risk-taking activities, it can lead to lots of health problems and certainly distress. So let's talk about a few studies that have talked about this impact of trauma. So Ford and Coto has mentioned that the risk of developing PTSD is greater for those with complex and repeated trauma. 33 to 75% for complex and repeated trauma, as opposed to 10 to 20% for a single trauma. We're talking about repeated trauma and complex trauma like a sexual abuse, and especially if within home, that's confusing and complex. Those chronically exposed to potentially traumatic experiences had almost double the risk of developing psychiatric disorders, particularly anxiety and depression. So I want to highlight here, we are not only talking about children. So my colleagues working with adults or old age, it is equally relevant to you, because we are going to talk about that anxiety or depression in adolescents actually predict a 2 to 3 times increased risk of similar problems in adulthood, along with a number of other factors where it's impacting, like the lower academic achievement, so lower work productivity, and increased risk of functional impairments and interpersonal problems. Chronic trauma exposure and resulting changes in neural structures and sensory systems are central to arousal, executive functioning, memory, affect, and behavioral regulation. And that sets the stage for later psychiatric and somatic illnesses. So what I want to highlight here is that it's providing a very fertile soil for development of future mental health problems. Even if we say that, yeah, things are okay now, nothing is, the child is, or the young adult who went through this abuse is feeling okay. Well, actually, the neuroimaging studies have shown that the brain after the trauma is different. There are actual neurological changes in the brain, and that provides a fertile soil for future psychiatric problems. Similarly, exposure to multiple potentially traumatic events in childhood is associated with greater with greater psychological mental health problems, but also more physical health problems, including cardiac, metabolic, immunological, and GI related illnesses later in life. And interesting thing is that if you are traumatized, it is likely to lead to more trauma. We'll talk about it why, but there are some risk factors, and some people are at increased risk of repeated traumatization and even leading to early death. So some things that we know about, and that it doesn't come as a surprise, that if there are more adverse childhood experiences, it raises the risk of depression. So on the x-axis, we have got the ACE score here, and on the y-axis, we have got the lifetime history of depression. So it's not a surprise. Women are more common than men, and there is more risk of depression. What did come as a bit more of a surprise was the alcoholism. So again, from the Fidelity study, the risk of alcoholism, and that can be extrapolated to other drugs addiction as well, is also increasing with the increasing number of adverse childhood experiences. And similarly, for the physical health problems, the risk is more, which we'll talk about. And interestingly, there is a dose-response relationship, meaning the more the number of adverse childhood experiences you had, the more likely you are going to develop serious mental health and physical health problems. So here, if we, I'm not sure if you can see my arrow cursor, but we are talking about the ACEs at the bottom. That leads to neurodevelopmental problems, It can lead to difficulty in focus, even cognitive and learning difficulties, behavioral problems. A lot of those children can be misdiagnosed. I'm not saying side. And of course, the risk of alcoholism and IV drugs goes also significantly high. Some of the risk factors following a trauma include female, low socioeconomic status. So these are the risk factors that are pushing you to develop more serious mental health problems or a full-blown PTSD picture. Because not everybody does, but those who do, why? So in the study by Goldman and Gallia, they found that, yeah, those females belonging to low socioeconomic status and a history of mental health conditions before or in the family, if they have comorbid physical health problems and previous history of traumatic exposures like any abuse or neglect at home or high expressed emotions at home, or they have gone through some bereavements, and even racial profiling, even the discrimination and prejudice according to your race. So belonging to the BME, or as it is called now, BAME, the Black, Asian, Minority, Ethnic, they have an increased risk and even increased media exposure. So they increase your risk of developing serious mental health problems in the future. As the low IQ, limited social support, and repeated traumatization. The vulnerable population here is, we've talked about those risk factors. We need to talk about some of the children with special needs. We all have around us, and we see those children or young adults who have special needs. So either with intellectual or learning disabilities or with developmental disabilities, including autism spectrum and related type of disorders, or ADHD and other behavioral disorders. They are up to 3 times more likely to be maltreated than their peers. So the risk of trauma is more in those children who are vulnerable. And then the impact is also more significant, which can mimic like they have just autism. But actually a child with autism is already more at risk of developing, suffering from trauma. And if they do suffer trauma, they are 3 times more likely they're going to have more severe symptoms later on, which may not be properly diagnosed or identified. Additional factors such as social isolation, family stress, and poor communication skills, of course, increase the risk of maltreatment. And yeah, it's quite common. So it's just something to keep on the front of our mind when we are dealing with children, that are we missing any aspect of neurodevelopmental disability? So we need to keep these 2 things always in our mind: the impact of trauma and any childhood neurodevelopmental disorder, because they both can really mimic each other. Why? Why are we talking about it? Let's get to the core of these golden circles. So in one of my favorite books, The Body Keeps the Score by Van der Kolk, he says that it helps us to understand why the people who are most hurt are more likely to hurt themselves and others, especially if they never have the opportunity to resolve their trauma. As clinicians, we are all dealing with people who either hurt themselves or others, emotionally or physically. We need to understand why they are doing that more. It's very easy to diagnose, of course, but we need to understand what's the root cause. And very often it lies at the very basis of that, in the trauma that they have experienced themselves. And that's why it's very important for us to understand, not only just diagnose PTSD and treat it pharmacologically or otherwise, but we need to understand why. Of course, we know PTSD can be chronic even after single traumas, but child sexual abuse, it increases the risk of anxiety, depression, substance use, suicide attempts, child sexual exploitation, and even psychosis, which may come as a surprise, but there are a number of studies which are associating childhood sexual abuse to development of psychosis and eventually schizophrenia. So it's not only the emotional disorders of anxiety and depression, it is about psychosis as well. There is a strong association with self-harm. Interestingly, children of parents who have experienced sexual abuse are more likely to self-harm, according to a study. So we are talking about intergenerational patterns. There is a concept of complex PTSD now becoming quite common. And it is PTSD features along with the history of attachment disorders. Briefly, before we go on to the etiology and management, evolution, Freud, well, the father of psychoanalysis, Sigmund Freud, of course, he talked about the traumas and sexual abuse, whether we love him or hate him, but he clearly put his finger on something that we have found to be correct in many different ways. There are different models. One of the models is the transactional model of stress by Lazarus and Folkman, which talks about dealing with trauma as a balance between the trauma, stress itself, with the resources that you have got. So those children or young adults who have better resources are more likely to cope with the same type of trauma as compared to those who do not have the resources. We know about the stress diathesis models of depression. Different people have different responses to stresses. The term PTSD, I'm not going to talk about in detail, but of course we know that it started from DSM-3 around 1980 when it was first used. Then it has gone through DSM-4 and until recently in the DSM-5, the core features, we'll talk about it in a minute, according to the avoidance and the hyperarousal and the flashbacks, but they are quite common, although they don't always have to be present after the trauma to be recognized. And the famous Brown and Harris study in relation to the depression conference we are in now, he talked about the stressful life events. So in the study by Brown and Harris, 90% of women who developed first episode depression had experienced a stressful life events. So the women, when they followed them up after the first episode depression, a lot of them had experienced some stressful life event. But in the same study, what they did found was a lot of women actually experienced the same type of life event, but they did not develop depression. So here I'm moving to my summary, and this is a slide that I have prepared, which I think summarizes a lot what I have said so far. And I'd spend a couple of minutes on it. That at the very bottom, I have put the trauma, abuse, and neglect, which in my view are the root cause, along with a lot of other stressors. Of course, academic stress, social stress. There are lots of social pressures, and then comorbid physical health problems, the world events like the one that we are going through now. And our children are going through a lot of these social media or cyberbullying stress. There are lots of these stresses. They put our children, our young adults, through a poor cognitive appraisals. They develop fear of upsetting others and poor self-esteem. That leads to then all these mental health problems, which in my view are manifestations of something underlying. So a lot of these internalizing problems, which we commonly associated with females, and a lot of externalizing or behavioral problems, commonly associated with males, like conduct disorder, psychopathy, drugs or alcohol or ADHD, and anxiety, PTSD, OCD, depression. Of course, they can be present in both males and females. So that sets a stage for development of all these problems here. What often is a barrier is the stigma that do not let our families, our children, to actually seek help. So stigma is really important. Otherwise, we can do whatever we want. But unless people are reaching to us, we are almost useless. So I'm highlighting the importance of prevention and early intervention here. On the right side, sorry, I think somebody's mic is on.
Sorry, Dr. Saqib. Mr. Khalil, can you mute your audio? Okay, I think it's okay. You can go ahead, doctor.
Okay. So on the right side, I'm highlighting the same statistic that as we found out that about 14% had 4 or more of adverse childhood experiences. So a lot of children, about 1 in 10, roughly speaking, go through these experiences. Not all of them develop these problems. Only 1 in 4 develop. Why not? And that's where comes the concept of emotional resilience. And we'll talk at the end about resilience. So clearly, we can provide the protection or safety to our children to prevent the impact of the trauma, even if it has experienced. And of course, the trauma could be a product of the genetic or environmental or the ACE, adverse childhood experiences. I'll skim through the etiology bit because of the time. So we know about the limbic system. We also heard about the emotional brain, the limbic brain, the amygdala, the importance of amygdala, which is the storage of the emotions, and hippocampus, as we know, is the storage site for emotional memories. But we also know the importance of then not only the limbic system, but the HPA axis, the hypothalamic pituitary adrenal axis. So we know what happens. If you're talking about the fight and flight or freeze reaction, the common example that we know, that we are sitting here in an office, and what would happen if a lion comes in here? Of course, our body and brain will react in a way where our HPA axis will be rightly activated. And of course, we'll produce some hormones. We know about the sympathetic and parasympathetic systems. So I'm not going to go into that detail, but just imagine if that lion appears every day or randomly, and the child is afraid of that threatening person or event happening on an unpredictable basis. Can you imagine what would happen to your HPA axis? So once the HPA axis is overactivated during the developmental process, it remains permanently unstable, overdriven, vulnerable, or dysfunctional, possibly due to transcriptional or epigenomic mechanisms, meaning it starts impacting the expression of certain genes. And these childhood life events and HPA abnormalities, they may be aspecifically and transnosographically related, not only to anxiety related, but actually other psychiatric disorders as well. So that's the same point I'm making, but it's from a very good meta-analysis where they found out the importance of this overactivation of HPA axis. Briefly about genes, there are lots of us who would talk about whether it's all in genes, nature, or nurture, environment. I think it's definitely a product of both. We know about it. Heritability estimates for any type of these disorders is significant, but it does not account for all. So genes account for only some portion of the increase in risk among family members of an affected individual, which means that environmental factors must play a major role. So what we can do is, of course, to prevent the environmental damage. And here comes the importance of the attachment research. It's a huge, big topic in itself, but the attachment disorders in itself provide soil to develop further mental health problems in the future. Okay. PTSD. Commonly used nowadays, in fact, in the context of COVID-19, we are all talking about if we are going to see a pandemic of PTSD later on. I think there are certainly going to be a lot of these features, whether we see the whole full criteria of PTSD or not. What is PTSD? I'm not going to go through the symptomatology. A lot of you would be aware of it. But yes, we are talking about exposure followed by re-experiencing distress, certainly avoidance symptoms, and hyperarousal or hypervigilance. Increased startle response. But in children and young adults, one important point that I'm going to make that is that you would almost never see these type of symptoms in your first assessment. Children don't come to you and they say, I'm really feeling down, or I'm quite scared. Well, they may appear scared. Children, especially under the age of 11, 12, but even adolescents, they often present with physical complaints, tummy ache, headaches, chest pain, appetite change, vomiting, sensitive gag reflex. Some of them may explain some phenomena which are akin to derealization or depersonalization. But we need to look out for these things, the change in sleep, appetite, change in the functional performance in the school and relationships. Whether they're asking more questions, mama, what if this happens? What if we all die? What if you get corona? What these changes, of course, then it can impact on their cognitive effects like focus and school performance. And they can have behavioral problems I have already talked about. So children don't come with classical neurological symptoms. Children and even young adults, they come with a lot of different types of these behaviors. Self-harm is one of them, but certainly hyperactivity, social isolation, academic decline, stereotyped movements, bodily physical symptoms are some of them. And some children even show regression, means decline in their performance. Comorbidity is a rule rather than exception. So almost always there is, as I mentioned, that it provides a fertile soil for development of number of other problems. So almost always you would not find only one, like anxiety disorder. Usually always there is some depression and some other problems if you dig more deeper into that. So significant comorbidity is present along with alcohol abuse or drugs abuse. Finally, just a couple of slides about management. I'm not going to talk about the classical management in terms of the pharmacological and the use of SSRIs. I mean, I could, but of course, this is, I think my talk is not focused on the pharmacological management. So I'm going to really talk about what we can do in the context of this trauma therapy to help our children and young people. We always talk about that prevention is where it starts. So we need to be able to prevent. If it's not prevented, then early identify and try to provide the secure, safe environment to the child or young adult so that they don't suffer from the effects of that. That's where the concept of systemic therapy comes. No child or even adult is a single entity. Of course, we are all a part of a big system. So we need to involve the system. We know an insecure bond between a parent and child, it's an important contributory etiological factor. So the treatment needs to be aimed at improving these interactions. Any intervention solely targeted at the child or young adult is almost never going to be fully successful. We need to involve the whole system. Trauma-focused cognitive behavioral therapy, as we know, has been the mainstay. However, it has its limitations because it only affects the frontal or prefrontal part of the brain. In order to access the limbic brain, really we need to have other modalities. EMDR is one of the more effective strategies which is relatively recent, and there are not many studies showing its efficacies, but there have been some, one study in children and a few studies in adults which have shown that eye movement desensitization retraining actually can be quite effective in the treatment of PTSD or PTSD symptoms. But we're talking about resilience. There are lots of models of resilience. What is resilience? Of course, the ability to strike back after you have been hurt or traumatized. Now, that ability varies widely. Why? How can we determine which child is going to be more resilient? So that's the big question. We would like to make our children resilient. What do we need to do? So that's a big other separate topic. But here we are going to talk about the physical and mental health, well-being, ability to cope. Social support certainly provides that ability to have more resilience, having a purpose or meaning in life, and having positive emotions. This helps in the enhancement of resilience. I'll move on to the take-home messages for all my audience, that please keep in mind that these adverse childhood experiences are more common than we think they are. Each potentially traumatic event, or what we call as trauma, is different subjectively for each individual. So don't think that somebody sitting next to you in the bus is also going to perceive that event as you have perceived. No, that may be more traumatizing for them. And it has a profound impact on the physical and mental health well-being throughout the lifespan. And there is a dose-response relationship. More the trauma, more the impact. Comorbidity is almost always present. Anxiety, depression, eating problems, and even psychosis. Your complex patients, what we have been seeing in your practice, usually have both. History of abuse and neglect trauma, and some type of neurodevelopmental problems as well. So it's really vital to have a trauma-informed formulation. In my view, that's one of the best things that we can provide to our patients or families. Or psychodynamic formulation, which is trauma-informed. And usually 1 or 2 sessions is not enough for that. In order to get to the root cause, we really need to dig a bit more. And for that, the management ideally should be multidisciplinary, holistic, and should cover, as I said, both aspects, neurodevelopmental and trauma. But prevention, early identification, and intervention is the key to better outcomes. I'm very fond of schools-based intervention for our children, supporting resilience through family approaches and collaborative and outcomes-oriented whole family approaches the way forward. And always keep in mind the concept of ACE and the stressful life events, because they are really important in the later development of psychiatric problems. So whatever the age range you are seeing, it's going to be quite relevant for your work. Thank you very much indeed. I'm very happy for any questions or thoughts or comments.
Hi, Dr. Latif. I am Anuttama Sen. I'm doing my PhD on autism studies, and it was a wonderful presentation. First of all, I would like to congratulate you on that.
Thank you.
I hope I'm audible.
Yes, I can hear you. Yeah, thank you.
Okay.
Thank you.
Yeah. And just some questions I had in mind, which I thought of asking you regarding your presentation.
Sure.
So one thing that you have told about, that new biological abnormalities can come up as like along with the normal abnormalities like the gastrointestinal problems as well. So I just wanted to ask that after the trauma, like what exactly you meant by the new biological abnormalities? Like, is it some like the related ones, or something like a very different kind of a biological difficulty that the child faced actually?
I think I used the word physical health problems. Yeah, I think that's what you mean by biological abnormalities.
Yes.
Yeah, we can go back to the slide. So we are talking about somatization here. We are talking about lots of different types of physical health problems. No, they do not have to be related. It can be anything. It can actually be culturally determined, more like culturally determined than related to the trauma. So for example, after the bullying or after a child being punched in the canteen of a school, the child may complain for the tummy ache for one day, but after that, he's going to start complaining of the headache, or he will start complaining that I look at my heart is pounding very fast. So by developing new symptoms, biologic or physical health symptoms that I'm talking about, they may be totally independent or separate to the trauma, but that's the way of the brain really tricking the body. So that's the way of expression of the mental stress through body symptoms, which is very, very common in children and including children with autism. So yeah, that can be totally different, and it can be many other different types. For instance, when I was working in a different part of the world, in Pakistan, I was seeing a lot of pseudo seizures. And pseudo seizures, you know, is a presentation when a child or young person or adult comes with a epileptic fit, but actually there is no EEG abnormality, but that's a very classical fit. When I've moved to the other parts of the world, the manifestation is different. It's less of pseudo seizure. It can be more in other types of symptoms, or sometimes self-harm is another way of communicating. So yeah, it is often culturally determined rather than determined by the trauma.
One more thing, doctor, it's as you mentioned about the pseudo seizures, I just wanted to ask one thing. In case of autism, some children have an abnormal EEG graph, but they actually didn't experience, or the parents didn't experience the child having those seizures. So does these epileptic conditions is it interrelated with all the autistic individuals? Like
okay, well, it's a good question related to pediatric neurology. So my answer to that would be that if the EEG is abnormal, they really need to get consultation from a good pediatric neurologist. Yes, the answer is that autism and epilepsy are related. Yes, they are. So there is an increased risk of epilepsy in children with any type of neurodevelopmental problems, including autism spectrum. But you are right. Sometimes the child never has had any fits. But the EEG may be a little bit abnormal. Little bit means only in one lobe of the brain there is excessive discharge. In those cases, yeah, we can educate the parents that the child is at risk of developing fits in the future. And these could be the risk factors. For example, the bright lights, or when he's dehydrated or hungry, or those type of things. So it's very important for the parents to have that education, because the child may be at increased risk of developing future fits if the EEG is abnormal. But there is certainly a link between autism, neurodevelopmental, and epilepsy.
One last question I had in mind, that one thing you told, that the after effects of the trauma, sometimes it is misdiagnosed with ADHD. If you
Yes.
can elaborate on that.
All I would say about that is that this is what I do all the time. This is my bread and butter. And we need to be able to get to the bottom of this. So ADHD, of course, exists. And there is a particular type of profile we have to talk about. Yeah, the inattention, hyperactivity, impulsive behaviors, emotional dysregulation, that's ADHD. But as a clinician, it's our responsibility that we are not only doing that tick box. We're not only looking at the symptoms. We need to go back to the developmental history, look in a longitudinal way. How were things when the child was little, less than 7 years old? Were there problems at that time? For ADHD, the problems need to start from the early years. So for example, if a child of a 12-year-old come to me and mom's saying that for the last 6 months, 8 months, the child is really having poor focus and he's not listening to me and I'm getting complaints from the school. But a year ago, the child was fine. So in that case, of course, it's not ADHD. There is something else I need to find out. Maybe the child has been abused. Maybe actually there's been a major change in the family. So a proper holistic assessment and a developmental longitudinal interview is really important in order to find out the difference between true ADHD and a trauma sequel.
Thank you so much.
Adi, is there any other comments or questions? I'm happy for another few minutes.
Hi. Sorry. I'm also doing my PhD on disability studies regarding children with autism spectrum disorders. And I was wondering, after the trauma, is there a difference, neurobiological difference, whether a child will be aggressive or out-aggressive?
Right. So your question is whether there is a neurobiological difference, meaning there is something that we could predict.
Yeah.
Interesting question. I'm not aware of any neurobiological, meaning any neuroimaging tool or any other neurobiological test that we could do that will tell us how the child may react, more on externalizing side or internalizing side. No. However, again, a good assessment, pre-morbid personality. How was the child before the traumatic incidents? So the pre-morbid personality, looking at the developmental history, home environment, because if there are already high expressed emotions in the home, if there is abuse, then it is very much possible that the child may become more aggressive side. The personality of the child. So these are the relatively soft markers that could help us predict the response. But no, I'm not aware of any particular neurobiological tool that will tell us exactly how. And I don't think that's really possible. It may be, but I'm not aware. I don't think that we are that sophisticated yet.
Okay, thank you. Thank you.